My name is Dr. Aaron Kaufman from the Centers for Disease Control and Prevention. This presentation is for healthcare providers and will cover important information about Lassa fever. At the end, you will be able to describe the epidemiology of Lassa fever, describe the clinical presentation, identify 2 methods to diagnose Lassa fever in a clinical setting, and describe the considerations for clinical management of Lassa fever. I will start with an overview of Lassa virus, then move on to the epidemiology and the clinical presentation of Lassa fever. I will then talk about the keys to diagnosing Lassa fever, or LF, which will be used interchangeably, then move on to infection control measures to consider when caring for an LF patient, treatment, and finally a few words on post-exposure prophylaxis. Lassa virus is an old world arenavirus. The virus is named after the town in Nigeria where the first cases occurred in 1969. Lassa virus is an enveloped virus, meaning that the virus is coated with a lipid membrane. This membrane makes it very susceptible to disinfection, and it is easily killed by household bleach, detergents, soap, and other disinfectants.
For many years, Mastomys natalensis, also known as the multimammate rat, was assumed to be the sole rodent reservoir for Lassa fever virus. This rat has been found in West, Central, and East Africa. Additional rodent hosts have been recently identified, but their contribution to human illness is unknown. Lassa virus infection does not cause any apparent illness in the rodent. Infected rodents can shed the virus in saliva, urine, and feces for the length of their lives. Lassa virus is maintained within the rodent reservoir and is transmitted from rodent to rodent primarily by fighting, through bites and scratches from one infected animal to another. People can contract the virus from rodents through direct contact with infected rodent droppings, urine, saliva, tissues, or blood, and by being bitten by infected rodents. As we know, infected rodents shed Lassa virus in their urine, saliva, and feces. When fresh rodent urine, droppings, or nesting material is stirred up, tiny droplets containing the virus can get into the air. People can contract the virus by inhaling aerosolized urine or droppings. People can also contract the virus by eating food contaminated by rodent urine or droppings. Finally, in parts of the world where rodents are part of the diet, people may get infected when preparing rodents for cooking. In one study in Guinea, Mastomys comprised from 95 to 98% of rodents captured inside homes. The same study found that the mean trapping success of Mastomys was always higher inside houses than in proximal cultivation. During dry season, mean trapping success increased 2-fold inside homes and decreased up to 10-fold outside homes. Another study in Sierra Leone examined housing characteristics and rodent density, and found that ceilings, roofs, food stocks, and cooking appliances were frequently infested with rodents. Finally, studies in Sierra Leone and Nigeria have found an association between house hygiene, defined as waste disposal and food storage, and a history of Lassa fever in the household.
Lassa fever is endemic in many countries in West Africa, including Sierra Leone, Liberia, Guinea, and Nigeria. In addition, isolated cases have been reported in Côte d'Ivoire, Burkina Faso, Mali, Togo, Benin, and Ghana. This graphic depicts some examples of Lassa fever exportation to countries outside of West Africa. Between 1969 and 2024, 9 cases of Lassa have been imported into the U.S. Of these, 2 patients were suspected of having Lassa fever and were medically evacuated. 7 patients traveled to the United States by commercial airliner and were diagnosed with Lassa fever upon arrival in the U.S. It has been estimated that there are 100 to 300,000 cases of LF in West Africa per year, with 5,000 deaths per year. 80% of those infected with the Lassa virus experience mild or no symptoms. 20% develop severe multisystem organ disease. The case fatality rate among hospitalized patients is 15 to 20%. One study found that in parts of Sierra Leone, Lassa fever was responsible for 10 to 16% of all adult hospital admissions. Death is usually a result of multi-organ failure. In endemic countries, the peak incidence of Lassa fever cases occur during the dry season, which typically runs from January to May. Mastomus breeds at the end of the rainy season, increasing the number of Lassa virus-infected rodents during the dry season. In addition, low humidity during the dry season creates more favorable conditions for aerosolized Lassa virus. This graph shows the incidence of Lassa fever cases and cases of non-Lassa febrile illnesses by month and average monthly rainfall in Sierra Leone over a 1-year period. As you can see, there is a peak in Lassa fever cases in the dry season. However, over the course of the dry season, Lassa fever incidence tends to be stable. In contrast, non-Lassa febrile illness incidence tends to vary more during dry and wet seasons.
Lassa virus can spread person to person through broken skin or mucous membranes, by direct contact with the body fluids of a person who is sick with or has died of Lassa fever, including blood, urine, vomit, breast milk, semen, and saliva. Transmission can also occur through direct contact with objects contaminated with the body fluids of a person sick with or who has died of Lassa, such as contaminated needles. Lassa virus has been detected in the urine and semen of Lassa fever patients for several weeks after the patient has recovered. There is no evidence supporting airborne spread of the virus between humans. This table depicts the general progression of signs and symptoms over the course of infection. During the first few days of the illness, symptoms tend to be mild in nature and include low-grade fever, chills, and malaise. Over the course of the next several days, patients exhibit signs and symptoms of a systemic viral illness, including nausea, vomiting, myalgia, and pain in the chest, epigastrium, and lower back. Headache is almost universally present and tends to be more frontal than occipital in location, and usually increases in severity later in the illness. Pharyngitis develops early and becomes progressively more severe during the first week, with oral ulcerations noted in half of the cases. Joint pain, particularly in the large joints, is common in this phase, as is low back pain. During the second week, severe lower abdominal pain and intractable vomiting is common. Facial and neck swelling with conjunctival edema and injection is frequently observed as well. Occasionally, patients demonstrate bleeding from the nose, gums, or needle puncture sites. The appearance of a maculopapular rash, cervical lymphadenopathy, crepitant rales, and deafness can also be seen during this phase of the illness. This graph depicts the frequency of various signs and symptoms in confirmed Lassa fever patients and patients diagnosed with a non-Lassa febrile illness. On first presentation, patients with Lassa fever have few pathognomonic signs and symptoms compared with other non-Lassa febrile illnesses. The lack of pathognomonic signs and symptoms makes diagnosis challenging without early suspicion and appropriate travel or exposure history. A review of 33 imported cases of Lassa fever found that the time from patient presentation for medical care to clinical suspicion of Lassa fever by clinical providers in their destination country ranged from 1 to 22 days, with a median of 4.5 days. In survivors, fevers begin to resolve during the second week of illness, with occasional spikes in temperature. Other symptoms also begin to resolve. The mean duration of illness for survivors is 14 days, with a range of 11 to 21 days. Non-survivors develop hypotension, shock, agitation, or lethargy, and eventually obtundation. The mean duration of illness in non-survivors is 12 days, with a range of 12 to 15 days. Laboratory findings of patients with Lassa virus infection often include lymphopenia, with maximum depression at 11 days after illness onset, thrombocytopenia and platelet dysfunction, and proteinuria. Elevated liver enzymes with AST greater than ALT is also commonly seen. Coagulation factors, including PT and PTT, are usually normal, even in patients who develop bleeding. Signs of renal dysfunction can also be seen, with elevated BUN and creatinine values. Sensorineural hearing loss is a known complication of Lassa fever. The hearing loss can be temporary or permanent in one or both ears and can occur in 20 to 30% of patients. Hearing loss typically appears during early convalescence. The onset of deafness is always preceded by seroconversion and is thought to be immune-related. Development of hearing loss is not related to the severity of the acute illness. In pregnancy, Lassa fever causes high maternal and fetal mortality. Compared to non-pregnant women, pregnant women with Lassa fever have significantly higher concentrations of the virus in their blood. Vertical transmission of Lassa virus from mother to child has been documented. Lassa virus has been isolated from fetal tissue following a spontaneous abortion. In addition, high concentrations of the Lassa virus have been detected in placental tissue. This table depicts the case fatality rate for pregnant women with Lassa fever by pregnancy trimester for one hospital in Sierra Leone. In this study, the highest risk of maternal death in pregnant women with Lassa fever was during the third trimester, with a case fatality rate of 30%. However, the overall case fatality rate in pregnant women is not statistically different from the case fatality rate among non-pregnant women admitted to the hospital with Lassa fever, except in the third trimester. Evacuation of the uterus by spontaneous abortion, evacuation of retained products of conception, or normal delivery has been shown to significantly improve the mother's chance of survival. In one study, 38% of women without uterine evacuation died, compared to only 10% of women with evacuation who died. This difference in mortality was statistically significant. Here is a table of fetal outcomes by pregnancy trimester for one hospital in Sierra Leone. As you can see, Lassa fever carries a high risk of fetal death throughout pregnancy. In this study, the overall fetal death rate in the first or second trimester of pregnancy was 92%. The overall fetal death rate in the third trimester of pregnancy was 75%. To evaluate signs and symptoms of Lassa in children, one study evaluated 479 children admitted with a febrile illness to 2 hospitals in Sierra Leone over a 4-year period. A total of 51 cases of Lassa fever were identified. The age range for Lassa fever cases was younger than 1 year to 14 years of age. 16 of the 51 cases were male. The overall case fatality rate was 12%. Of the 51 confirmed cases of Lassa fever, signs and symptoms were recorded for 26 of the cases. The most commonly reported symptoms were fever, cough, and vomiting. The most commonly noted signs were pharyngitis, lethargy, and bleeding. Overall, the signs and symptoms of Lassa fever in children were similar to those in adults. However, compared to adults, sore throat and pharyngitis were much less frequent in children. Swollen baby syndrome is a clinical syndrome that is distinctive and highly diagnostic of Lassa fever in children. It can be seen in the neonatal period, infancy, and early childhood. It is characterized by a triad of symptoms including widespread edema, abdominal distension, and bleeding. The edema of swollen baby syndrome is pitting, but in the extreme form can be tense like a balloon. There may also be chemosis and pulmonary edema with crepitations and foaming at the mouth. Initially, the edema may be confused with nephrotic syndrome. However, serum creatinine and albumin are normal, and albuminuria is minimal. Abdominal distension may be severe and tympanic, requiring placement of a rectal tube. Bleeding presents as hematochezia, melena, hematemesis, subcutaneous ecchymosis, bleeding from the cord, and bleeding from venipuncture sites. Swollen baby syndrome is associated with a poor prognosis. The key to diagnosing LF is to ask about risk factors for the disease. What time of year is it? Peak cases of LF are seen during African dry season. Has the patient been in contact with someone suspected of having LF? Perhaps they cared for a loved one who was ill. Did the patient have an occupational exposure to Lassa fever? Did they care for an LF patient in the clinic or hospital? It's also important to ask about exposure to rodents and rodent droppings. Did the patient hunt, prepare, or eat rodents, or recently clean rodent droppings? Does the patient live somewhere with a rodent infestation? Genomic sequencing of Lassa virus strains has revealed high sequence diversity and at least 6 major genetic lineages which correlate with geographic location. The high degree of sequence divergence of Lassa virus genomes poses a significant challenge to the development of molecular diagnostic technologies. The method of choice for the early detection of Lassa virus in the blood is reverse transcriptase polymerase chain reaction, or RT-PCR. However, the genetic variability of the Lassa virus genome poses a problem for reliable detection of all virus strains. As such, multiplex assays are recommended for detecting all described Lassa strains. Enzyme-linked immunosorbent assays, or ELISA, capable of detecting IgM and IgG antibodies to Lassa virus are also available. However, it should be noted that detectable antibody response does not necessarily signal imminent recovery, and viremia frequently persists and some patients die despite an antibody response. Virus isolation is also available, but requires a biosafety level 4 laboratory.
With regards to infection control, early identification of suspect Lassa fever patients is key. Identify, isolate, and inform is used to describe the initial process of identifying the possibility of a pathogen, isolating the potentially infectious patient to protect healthcare providers and the community, and inform the appropriate authorities. While evaluating a patient for Lassa fever, it is important to maintain a posture of recommended infection control in the healthcare facility while providing effective care. The patient should be placed in a single room containing a private bathroom with the door closed. Visit CDC's VHF IPC website to learn more about infection prevention and control measures for patients with suspect or confirmed Lassa fever. Personal protective equipment, or PPE, should be worn by all personnel entering a suspect or confirmed Lassa fever patient's room. For clinically stable patients suspected of having Lassa fever who do not have bleeding, vomiting, or diarrhea, recommended PPE includes single-use or disposable fluid-resistant gown that extends to at least mid-calf, or single-use or disposable fluid-resistant coveralls without integrated hood, single-use or disposable full face shield, single-use or disposable face mask, single-use or disposable gloves with extended cuffs. 2 pairs of gloves should be worn. At a minimum, outer gloves should have extended cuffs. More detailed guidance on the recommended PPE for healthcare providers caring for a clinically stable suspect Lassa fever patient and proper procedures for donning and doffing can be found on CDC's Viral Hemorrhagic Fever, or VHF, website. For patients who are confirmed to have Lassa fever or who are suspected and are clinically unstable or have bleeding, vomiting, or diarrhea, recommended PPE includes impermeable garment, single-use or disposable impermeable gown extending to at least mid-calf or single-use or disposable impermeable coverall, respiratory, head, and face protection, PAPR or disposable NIOSH-approved N95 respirator, single-use or disposable examination gloves with extended cuffs. 2 pairs of gloves should be worn. At a minimum, outer gloves should have extended cuffs. Single-use or disposable boot covers. Single-use or disposable apron if patients are vomiting or have diarrhea. Again, more detailed guidance on the recommended PPE for healthcare providers caring for a patient confirmed to have Lassa or a suspect patient with Lassa who is clinically unstable or has bleeding, vomiting, or diarrhea, and proper procedures for donning and doffing can be found on CDC's Viral Hemorrhagic Fever, or VHF, website. Routine laboratory testing to monitor the patient's clinical status and diagnostic testing for other potential causes of illness should be pursued while evaluating and/or testing for Lassa fever. This testing can be safely and effectively performed by following the standard precautions for all patient care and the blood-borne pathogen standard. Dedicated medical equipment should be used for the provision of patient care, preferably disposable when possible. All non-dedicated, non-disposable medical equipment used for patient care should be cleaned and disinfected according to the manufacturer's instructions and hospital policies. Inform the jurisdictional health department if you think a patient may have Lassa fever. A consultation with CDC is recommended and would be coordinated by the jurisdictional public health department. CDC can leverage national and international resources to provide context around the patient's travel and activities to identify potential epidemiologic risk factors. This consultation provides a forum to weigh the pros and cons of testing, discuss the need to maintain recommended infection control precautions, and collectively make decisions that are in the best interest of the patient and public health.
The mainstay of treatment for Lassa fever is supportive, to include the provision of intravenous fluids and electrolytes to maintain homeostatic balance, antipyretics, and treatment for co-infections like malaria. Administration of ribavirin to treat Lassa fever has been well studied in animal models and has been shown to reduce mortality in humans when given early in the course of the disease. I will review some of the data on ribavirin in the next few slides. There are new treatments in the pipeline for Lassa fever as well. I will briefly discuss two, favipiravir and monoclonal antibodies. Ribavirin is a guanosine analog with broad-spectrum antiviral activity. The specific mechanism of action against Lassa virus has not been investigated. It's available in oral and intravenous formulations and is renally excreted. Ribavirin has been shown to be teratogenic and embryotoxic in rodents and is therefore contraindicated in pregnancy and while breastfeeding. However, due to the high case fatality rate of Lassa fever in pregnant women, ribavirin has been administered to pregnant mothers during outbreaks in endemic countries. Ribavirin has been associated with a number of adverse effects, although most are mild and all are reversible with cessation or dose reduction of the drug. No deaths from the use of oral ribavirin are known. This is a graph of adverse side effects reported by 23 contacts who were prescribed ribavirin as a post-exposure prophylaxis measure. The most common adverse effect was weakness, reported by 9 of the 23 contacts, followed by dizziness, reported by 7 contacts, and headache, reported by 6 contacts. One study found that AST levels greater than 150 international units and viremia greater than 10 to the 3.6 TCID50 per milliliter were associated with high LF case fatality rates. This study found that IV ribavirin administered within 6 days of illness onset decreased mortality in LF patients with AST greater than 150 international units from 55% to 5%. The study also found that IV ribavirin administered within 6 days of illness onset decreased mortality in LF patients with viremia greater than 10 to the 3.6 TCID50 per milliliter from 76% to 9%. Here is the dosage of intravenous ribavirin administered in this study. Ribavirin for treatment of Lassa fever is available through FDA's Emergency Investigational New Drug Program. Here is the dosing information. Favipiravir is an antiviral agent that inhibits the RNA-dependent RNA polymerase of influenza viruses. In vitro and in vivo studies suggest that favipiravir exhibits broad-spectrum antiviral activity against a variety of RNA viruses. The drug is administered orally and is renally excreted. One study compared favipiravir and ribavirin in experimentally infected Hartley guinea pigs. Guinea pigs receiving 300 milligrams per kilogram a day of favipiravir were completely protected from lethal Lassa virus infection when treated 2, 5, 7, and 9 days after experimental infection. The study also found that survival in guinea pigs who received subcutaneous favipiravir was higher than in guinea pigs who received subcutaneous ribavirin. Another study looked at the therapeutic potential of favipiravir, both alone and in combination with ribavirin, in experimentally infected mice. The study found that all mice administered oral favipiravir 4 days after experimental infection at a dose of 300 milligrams per kilogram a day for 8 days survived. 60% of mice survived after being administered intraperitoneal ribavirin at 160 milligrams per kilogram a day and oral favipiravir at 150 milligrams per kilogram a day, starting 4 days after experimental infection. The author concluded that there was a synergistic interaction between favipiravir and ribavirin, resulting in increased protection from mortality when combining suboptimal doses. 2 Lassa fever patients were recently treated with both ribavirin and favipiravir. Here are the dosages that were administered for each drug. Favipiravir was started on day 8 for one patient and on day 5 for the other patient. Favipiravir was discontinued after 5 days of treatment in both patients due to nausea and worsening transaminases. It was unclear whether these symptoms were due to Lassa fever or favipiravir. This is a graph of the PCR and culture results for each patient. Filled symbols represent body fluid samples from which a viral isolate was recovered. Positive culture results and positive qualitative PCR results are indicated by cycle threshold values ranging from 10 to 15. Symbols below the red bar indicate body fluid samples testing negative by PCR. The presence of immunoglobulin G, immunoglobulin M, duration of treatment, duration of symptoms, and duration of clinical examination findings are indicated by the bars underneath. Lassa IgM was detected on day 13 in patient E. Lassa IgM was not tested in patient F. Lassa IgG was detected on day 46 for patient E and day 38 for patient F. Varocell culture for Lassa virus was positive from whole blood specimens from patient E on days 8, 9, and 11. For patient F, varocell culture for Lassa virus was positive from whole blood specimens on day 5. Lassa virus was detected by RT-PCR in blood samples collected through day 59 in patient E and through day 28 in patient F. Urine from patient E was RT-PCR positive for Lassa virus until day 31 and day 25 in patient F. Saliva was positive for Lassa virus through day 46 in patient E and day 28 in patient F. Semen samples were positive for Lassa virus by RT-PCR through day 48 in patient E and day 103 in patient F. Culture yielded Lassa virus in one semen sample from patient E on day 20.
Studies in survivors have demonstrated Lassa virus persistence in semen. One study detected Lassa virus RNA in seminal fluid up to 12 months after recovery from acute infection. Low concentrations of Lassa fever virus RNA were also detected in saliva, lacrimal fluid, and vaginal fluid in survivors, but cleared within 3 months post-recovery.
Ribavirin has also been studied as a post-exposure prophylaxis measure, or PEP, for Lassa fever. No data exists on the efficacy of ribavirin PEP for LF in humans. However, studies of ribavirin PEP in animal models for LF has shown efficacy when administered within 6 days of infection. One study found that subcutaneous ribavirin protected rhesus monkeys from fatal LF when started up to 5 days after infection. Clinical illness was mild and brief in the group that received ribavirin immediately after viral inoculation. Clinical illness was more severe in those monkeys who received ribavirin 5 days after infection, but all survived without evident sequelae. Another study found that intramuscular ribavirin protected cynomolgus monkeys from fatal LF when started up to 6 days after virus inoculation. However, 4 of 8 ribavirin-treated monkeys survived when ribavirin was delayed until day 7. Ribavirin has been given for post-exposure prophylaxis for LF. One study in Sierra Leone retrospectively interviewed 23 family members and healthcare workers who had direct contact with a confirmed LF patient who were prescribed ribavirin PEP. The oral PEP ribavirin dose prescribed was 800 milligrams a day for 10 days. The mean age of individuals who received PEP was 38 years, with a range of 23 to 73 years of age. 17 of the 23 reported exposure to infected body fluids while bathing, cleaning, or feeding a confirmed LF patient. 6 of the 23 reported in-hospital contact with blood and body fluids from a confirmed LF patient. None of the 6 reported a needle stick exposure. 10 of the 23 contacts who were prescribed ribavirin PEP completed the full 10-day course. There was no evidence of secondary transmission of Lassa virus by report or antibody testing. However, only 8 of the 23 who were prescribed PEP agreed to testing for Lassa virus antibodies. All tested negative, including one contact who reported fever and malaise after exposure to an LF patient. The remaining 15 contacts who were prescribed ribavirin PEP refused testing for Lassa virus antibodies and reported no symptoms consistent with LF. Ribavirin was also administered to 16 high-risk and close contacts following an imported case of LF in Germany. In this instance, oral ribavirin was administered at a dose of 10 milligrams per kilogram 4 times a day for 5 to 8 days. Temporary side effects were reported among those who were given oral ribavirin PEP, including reversible elevated bilirubin levels in 11 people and decreased hemoglobin in 9 people. One person stopped PEP after 4 days due to jaundice. Another person stopped PEP after an increase in serum lipase. None of the 16 people given oral ribavirin PEP reported signs or symptoms consistent with LF. One person who started ribavirin 36 hours after exposure developed Lassa virus-specific immunoglobulin G, but remained asymptomatic. Ribavirin was also administered to 7 contacts who had direct contact with the blood and/or body fluids following an imported case of LF in London. In this instance, oral ribavirin was administered at a dose of 600 milligrams 4 times a day for 10 days. Due to concerns that ribavirin could prolong the incubation period for LF, the period of temperature monitoring for those receiving ribavirin PEP was extended by 10 days. Several temporary side effects were reported among those who were given oral ribavirin PEP and are listed in this table. The most commonly reported side effect was fatigue, followed by headache and irritability. One contact discontinued ribavirin after 7 days due to jaundice. No instances of secondary transmission were reported. In 2010, a review of the literature and proposed guidelines for the use of oral ribavirin as post-exposure prophylaxis for Lassa fever was published. The review advised against the liberal use of ribavirin for PEP due to the following factors: low secondary attack rate for LF, the efficacy of ribavirin PEP in humans is unknown, reaching the minimum inhibitory concentration for Lassa virus is not assured with oral administration of ribavirin at tolerable doses, and adverse events following ribavirin administration are frequent and may mimic LF symptoms. These guidelines advised ribavirin PEP exclusively in the event of a high-risk exposure, defined as one of the following: penetration of skin by a contaminated sharp instrument, contamination of mucous membranes or broken skin with blood or bodily secretions, participant in emergency procedures to include resuscitation after cardiac arrest, intubation, and/or suction without use of appropriate PPE, or prolonged and continuous contact in an enclosed space without use of appropriate PPE. This is the recommended oral dose of ribavirin in these circumstances. The ribavirin dose should be decreased in people known to have significant renal insufficiency. Intravenous ribavirin for post-exposure prophylaxis was not recommended.
Studies in survivors have demonstrated Lassa virus persistence in semen. One study detected Lassa virus RNA in seminal fluid up to 12 months after recovery from acute infection. Low concentrations of Lassa fever virus RNA were also detected in saliva, lacrimal fluid, and vaginal fluid in survivors, but cleared within 3 months post-recovery.
Here is a list of references cited in this presentation. Thank you for your attention.